right, AMS, strokes, and headache. Altered mental status. That's what we're going to be talking about here. All right, so some causes of AMS. Shock. Drugs that depress the central nervous system. What are some drugs that depress the central nervous system? Downers. Specifically, heroin, which is an opioids. Okay, opioids depress the central nervous system. All right, so this kind of ties back into what we were talking about last week when we talked about how we treat this. How do we treat this? How do we treat someone of an opioid overdose? Narcan. Awesome, awesome, awesome. Okay, that post-seizure state, what is that called? The post-ictal state, the post-ictal state. Infection or sepsis, cardiac rhythm disturbances can cause this, or a stroke. All right, we're always going to do that scene size up, check for scene safety, etc., etc., etc. Okay, if they are in a hazardous environment, we're going to remove them. Okay, now if it is a danger to ourselves, we're not going to go in there. Okay, we're going to call for somebody that can. But a hazardous environment could be they are out in the sun. Okay, someone has a episode of heat stroke, so we're going to move them from that environment. If necessary, okay, C-spine precautions, ABCs. ABCs. This is going to be very important when we're talking about altered mental status because we don't know exactly why they're having this problem. We gotta suss it out. We gotta figure it out. So we're gonna go through our decap BTLS and then our OPQRST and sample. We're gonna figure out what's going on with this patient. Okay, so some possible findings in trauma. Okay, so if we see obvious signs, okay, yeah, here we got it. Maybe a depression of the skull. That's pretty obvious signs. Abnormal respiratory pattern or rate or unequal pupils. Unequal pupils can be a good sign of what when we're talking specifically about trauma? Brain injury or a head injury of some kind. High or low blood pressure. Okay, if it's excessively low blood pressure, what might we suspect? What type of God, I'm trying to find the word. We had this chapter a while ago when we were talking about I'm gonna have to look it up. I'm gonna have to pull up my my homework. Study hall, study material. No. Shock. Oh my God, I couldn't remember. Well, shock. When we talk about excessively low blood pressure, what type of shock?
Whichever one it is where like you're losing body fluids.
What is that called? Hypovolemic shock. Hypovolemic shock. I want to make sure it's still recording. All right, yeah, we're still going. All right, so again, when we talk about signs and symptoms of shock, that pale, cool, clammy skin. What about discoloration behind the eyes or ears? Okay, or around the eyes and behind the ears. Around the eyes, what do we call that? Raccoon eyes. What's that a sign of? Head injury, like an orbital fracture. Okay, what is it called behind the ears? Battle signs. What is that indicative of? Basilar skull. Ugh, nail it. That's what I like to hear. Abnormal flexion or extension. What is that called? Abnormal flexion or extension. Think about your Glasgow Coma scale. If someone has an abnormal flexion, they're going into their body, into the core. What do we call that? What type of posturing? Decordicate posturing. Okay? Decordicate. What if their arms and wrists and their ankles are twisting outwards in their head? What is that called? We have decordicate posturing and decerebrate posturing. Know those two. Know those two. Probably going to see a test question. All right, so medical emergencies. This was based on trauma findings, but medical emergencies, abnormal vitals, hot, cool, dry, or hot, the pale, cool, clammy skin, but it also could be hot, dry skin. Okay, so what if the patient is excessively hot and their skin is dry? What do we think happened to them? Heat stroke. Okay, pinpoint pupils. What might that be? Could be another type of drug overdose. Okay, so if we see what do we see in what do we see in opioids? Oh, I hear dilated and I hear constriction. Which is it? Opioids make their pupils constrict. Opioids make their pupils constrict. Our other drugs like cocaine, amphetamines, what do their pupils do? Dilate. All right, so they may have a stiff neck. What might that be? A patient complains of a stiff neck. Or maybe they can't touch their chin to their chest. It's too painful. It could be spine, but if we have any suspected spine, we're not going to ask them to touch their chin to the chest. What about meningitis? Because that was a cause for seizures, remember? Meningitis. Lacerations of the tongue. Okay, so we talked about this. So maybe they bit down on their tongue during a seizure. They may have loss of bowel or bladder control or high or low glucose. Okay, so hypo or hyperglycemia. We're going to get into that next when we talk about diabetic emergencies. So what do? C-spine if necessary, ABCs, okay, and our decision to transport. Reassess every 5 minutes because these are what? What? So are they what so it's 5 or there we go. They are unstable patients. So every 5 minutes we're going to check. If they're stable, how often do we check? Every 15. These are unstable patients. All right, so in a child, I don't think you're going to get these test questions on here, but you might. This is what's called the pediatric assessment triangle, the PAT. Okay, so the PAT has 3 aspects of it. The first is appearance. Actually, we'll just say it. The first is appearance. Okay, so we're just looking at them. Next is their work of breathing. Is it difficult? Is it labored? Is it rapid? Is it shallow? Et cetera, et cetera, et cetera. And then lastly, circulation. Okay, what does their skin look like? Pale, cool, clammy, hot, dry, moist. Okay, cyanotic. What does cyanotic mean? Bluish. Okay. We're going to check their AVPU. Okay, this is when we're talking about a child. Okay, it's going to be the AVPU is going to be similar. Okay, but if you have like an infant that can't speak, I'm going to have to modify this a little bit. You know, when I talk, do they respond to my voice? Okay, obviously they can't repeat words back to me, or they can't talk to me, so maybe that's not going to be a possibility to ask those questions about are they oriented, because I have no way of knowing. Okay, but it's kind of a modified APU or a modified Glasgow Coma Scale. All right, so if necessary, we're going to establish and maintain their airway. What did we say is probably the best method to maintain their airway in these types of situations? An NPA. Okay, because we were talking about seizures earlier, and we don't want to put an OPA in their mouth because if they go back to a seizing episode, okay, they're going to bite down on it, probably cause damage to their teeth. Place the patient on their side. Why? In case they vomit. All right, which side? Left side. Left lateral recumbent position. Be prepared to suction and expedite their transport. All right, a bruit. A brief, unresolved, or unexplained event. Okay, so a bruit, I wrote this in here earlier. This is when an infant suddenly stops breathing. Okay, bruit. When an infant suddenly stops breathing, or they have a significant change of breathing that lasts less than a minute. That's what a bruit is. We may see cyanosis. We said that was bluing in the skin. What is pallor? Nope, the opposite. Pale. They are pale. Absent, decreased, or irregular breathing. What do we call absent breathing? Apnea. Excellent. A change in muscle tone. Okay, so we're talking about pediatric patients. If you were to come up to a patient and you're just, let's say an infant, and you pick them up and they're just completely ragdoll, okay? That is not normal. That is not normal. That's something that we need to take into consideration, and that's going to be a rapid transport decision immediately. Open to maintain their airway. Okay, ventilate their SpO2 is less than 94%. Okay, positive, so positive pressure if necessary. So pulling out that BVM, that special pediatric sized BVM. All right, why is it so important that we use a pediatric BVM? Because we want to get that proper size face mask, but why else? How easy would it be to blow out an infant's lungs with that big ambu bag? Pretty easy, okay? So we're going to use the smaller one. We're still breathing over the course of 1 second, but we don't want to damage their lungs. All right, so when we're talking about pediatric patients, we're not going to be breathing for them at a rate of once every 6 seconds. Okay, this is probably going to be once every 3 seconds. We want to breathe a lot more often for these patients, so that we're gonna have to breathe more often for our pediatric patients, especially these infants. Check their glucose level. Why? Why is it so important? Exactly. It could just be hypoglycemia. That could be the problem. That could be the cause of the altered mental status. Realistically, every patient, when you're getting a set of vitals, should get a BGL, blood glucose level. We're going to reassess every 5 minutes. Why? Because they are unstable patients. All right, we're going to go over that. All right, so here we're talking about geriatric patients. They may have different causes or reasons for their altered mental status. It could be dementia or delirium. Okay, there's no treatment for this. Okay, it's irreversible. It just continues and happens. What do we call that? What's like a subcategory of this? Alzheimer's. Okay. Additionally, these conditions can happen at different times of the day. What is that called? When like night falls and our patient becomes altered. What is it? Sundowning. Exactly. Awesome. Awesome. So this can happen at different times of the day. All right, here's just a breakdown when we're talking about dementia and delirium, okay? Because they are different. Dementia is not reversible. Delirium is, okay? So when we talk about delirium, we're going to get that a little more here in a second. And we mentioned this already. Alzheimer's, okay? Does not directly cause death, but it can cause the patient to stop eating. They don't necessarily stop eating, but they forget to eat. They just forget. All right, so we're talking about AMS here. This is also considered altered, but we're going to talk about kind of a little subcategory here, strokes. Here's an important note to keep in mind. A stroke is not a stroke until you rule out what? Yes, a stroke is not a stroke until you rule out hypoglycemia. Can hypoglycemia cause a stroke? Well, stroke-like symptoms. Yes. Can it cause a seizure? Yes. All right. Stroke is not a stroke until you rule out hypoglycemia. All right. So some important things to remember when we're talking about strokes. Time is a factor. What is that noise? Is that happening outside? Okay. All right. All right. So time is a factor here. So what is probably the most important question you can ask when you suspect someone has had a stroke? Well, last known normal. That's probably the most important question you can ask. When was their last known normal? All right, let's say grandma was fine at 9 o'clock last night. She went to bed shortly after, 9:15. You wake her up in the morning and she's having signs and symptoms of a stroke. When do we consider the stroke to have started? 9:15. Because we don't know. We can't confirm it. All we know is that she was fine at 9, she went to bed at 9:15, she woke up with stroke-like symptoms, or we found her with stroke-like symptoms. So it must have been happening from that very instant on. What are some signs and symptoms of a stroke? If you guys heard the acronym FAST, like we see up here, it's the best way to remember it. FAST. Facial drooping, usually unilateral. What's the A? Arm? What about the arm?
Like if one starts drooping or they both.
We have drift. Arm drift. Okay? And S? Slurred speech. Slurred speech. And then the T in FAST is time. Okay, that is time to transport. It is time to go. Or for the civilian population, time to call 911. So when we're talking about the facial droopage, the slurred speech, the arm drift, does the person having a stroke realize this is happening? No, they don't know it's happening. They do not realize or recognize that they're having a stroke. Okay, we're gonna talk. I don't know how deep this goes into it, but if it doesn't, I'm gonna talk about the different types of stroke. Okay. So the pathophysiology of stroke. Okay, so it is going to talk about it a little bit. All right, so you have what are called ischemic strokes. So ischemic strokes are strokes where we have a clot in the brain. We have a blood clot in the brain. So a little thrombus, okay, gets dislodged. Okay, the little blood clot just travels through our circulatory system. And it gets up to the brain and then boop, gets lodged. So that part of the brain doesn't get oxygen and it causes stroke-like symptoms. So in this example, let's look at that top-down view. Let's assume that's the right side of the brain that's affected. What part of the patient's body will we see signs and symptoms on? The left side. We will see signs and symptoms on the patient's left side. So their face will have that droopage on the, or may have the droopage on the left side. The arm drift will be on the left side. Okay, so when we're talking about causes of stroke, we talked about one, and that was that ischemic stroke. Okay, it could be an infarction, which what do we call a myocardial infarction? That's a heart attack. What is happening there? It's a loss of blood to a portion of the heart. Why? It could be a blood clot. It could be due to the vessels becoming clogged. Okay? So ischemia, or we have an infarction, okay, up in our brain. But there are other reasons, and I'm not even 100% sure it gets to it, but we're going to talk about it. So a stroke caused by a blockage is referred to as an ischemic stroke. All right, and it does. All right, so we also have hemorrhagic strokes. Okay, we have ischemic strokes caused by a blockage of the brain and hemorrhagic strokes. So we have a brain bleed. Now, in pre-hospital, this can be very difficult to determine the two. But there is one way that we might immediately know the difference. And that is because of a TIA, transient ischemic accident. So it's called a TIA, transient ischemic accident. So transient, traveling, ischemia, okay? We know ischemic stroke is caused by what? A clot, okay? So what happens in the TIA is that a clot occurs. Boom! They start having stroke-like symptoms. Their blood pressure increases. Why is blood pressure going to increase? Because the brain is like, holy crap, I need oxygen. I need to get blood circulating more, faster, harder. Okay, so blood pressure increases, and it could actually dislodge that clot. Boop. So the clot is now free floating. What is likely to happen again now that that clot has been dislodged and is moving around? Another clot. So they're going to have that seizure-like symptoms again. So a TIA is when we have stroke. I said seizure. When we have stroke-like symptoms. A TIA is when we have a stroke, and then it resolves typically within an hour. So they go from having all these problems to right as rain. Okay? They're done and dusted. They have no issues. And then now they are definitely in danger of having another stroke. So just offhandedly, how difficult do you think it is to convince these patients to go to the hospital? It is nightmarish. Okay? They don't want to go. They don't have any problem. They don't recognize any symptoms that are happening to them. It is almost impossible to get them to go. Can we force them to go? No, we can't. Unfortunately. But they need to go. So do everything in your power to convince them to go. Friends, family, try to convince them. And at the very least, ask them to call someone if they're out in public. And please don't let them drive. Try to convince them not to drive. Because there's a good chance that they'll have that stroke again while they're driving. Now, then we have just compounded issues if they get into an MVC. All right, so here's a good point right here. When we're talking about fibrinolytic drugs, it's difficult for me to say right now. What is that talking about? We're talking about clot busters. So when we ask that question, when was their last known normal? That is imperative for the doctors at the EDs. Because there's a time frame that they can receive this medication. Typically, it's about 4 hours from onset of symptoms. So grandma that went to bed at 9:15, we find her in the morning and she has stroke-like symptoms. Is she a candidate? No. Okay? She's not. Not on our end, at least, because we're going to assume that that episode started at 9:15. In reality, maybe it happened 5 minutes before someone checked her, but we don't know that. Okay? We don't know that. So we can have a buildup of that fatty deposits, okay, the plaque, okay, and some of it can break off, causing a thrombus or an embolism, and then we just have a stroke. So a patient that has a stroke will be given blood thinners. They'll be on those for the rest of their life. Why is that so important for us to note that? If they're non-compliant, okay, they might be in danger of having a stroke at any time. Or let's say we're getting a history of a patient. Okay, I know I'm mixing things up here because we're talking about medical emergency, but we're EMTs. We've got to think about the whole picture. Okay, if they're involved in a traumatic incident, we're doing that OPQRST. Say what? Yes, they're going to bleed out much, much faster. Okay, and if they have, let's say they have this type of ischemic stroke, they get put on blood thinners, and then later on they fall and hit their head, they might have a hemorrhagic stroke, and it's going to be difficult to control because they're on blood thinners. So just this nightmare scenario that just gets worse and worse the further we dive in. All right, hemorrhagic strokes. I was just talking about this. Results of a ruptured or weakened cerebral artery, okay? Or maybe they just fall and develop a brain bleed. All right, we don't really need to know that. All right, signs and symptoms depend on the area of the brain where the hemorrhage occurs. Okay, so we can see very different things depending on what part of the brain has the bleed. All right, so I mentioned this a second ago. Symptoms that disappear within 1 hour are typically called a TIA, that trans-ischemic attack, or sorry, I called it an accident. I mixed up the two. CVAs are called cerebral vascular accidents. Those are also known as strokes. This is a transient ischemic attack. I confused the two. CVAs, cerebral vascular accidents, versus a transient ischemic attack. My bad. All right, so the TIA, like I said, these resolve typically within an hour. Okay, they resolve typically within an hour. The signs and symptoms completely disappear from the patient, but that doesn't mean they're out of danger. We talked about this. Facial droop, okay, one-sided or unilateral weakness or paralysis we may see. TIA, okay, they typically resolve in less than 5 minutes, with the average being 1 minute. Okay, within an hour is typically when these symptoms are going to resolve. 10 to 15% risk of a stroke in the subsequent 90 days. That is huge. Okay, and it can occur immediately. It doesn't have to. We don't have to wait out the clock 90 days. It can happen again almost immediately. If our patient has AFib, they could be subject to these cryptogenic strokes. I don't think that you need to worry about this so much. Probably not going to see it on the exam. All right, so seeing size up when we're assessing our patient, this is going to be really important. Obviously seeing safety and just kind of get a whole of what's going on. That OPQRST is going to be vital. What were you doing when it happened? Does anything make it better or worse? Is there any pain involved? Okay, and then doing that stroke assessment. All right, we're talking about the different parts of the brain here. Okay, let's not worry about all this. We talked about this before. Some weakness or in the face or extremities. Okay, that facial droop. Problems walking, loss of balance or coordination because they have possible paresthesia or paralysis of the one side. Difficulty speaking, again, because they have paralysis of one side. And it may be a sudden severe headache. All right, sudden severe headache. This is typically, that they describe it as a thunderclap headache. This is typically associated with our brain bleeds. Our brain bleeds. That sudden severe thunderclap headache. Brain bleeds, which can lead to strokes, which can lead to death. These are all different types of screening tools, okay? You're probably going to be more familiar with RACE or the Cincinnati Stroke Scale. All right, and at the end of this, I'm going to give you guys an app that you can download that's free, okay, and all of you should have it. And in fact, what is it called? Because I have it here. Go to your apps, and I think you just type in stroke scales, and that should be it. Stroke scales for EMS. All right, perfect. Yeah. So if you go to your apps on your phone and type in stroke scales for EMS, there's going to be, the first one you might see is like Pocket Prep. It's not that. That's for studying. But the second one is it's red and has the word stroke on it. Okay. That is a free app, and that's a way that you can easily assess your patients for a variety of these different types of tests. Okay. The LAMS, the RACE, which is on here, the VAN, which is another one, MEND, which you see on here, the Miami Emergency Neurologic Deficit Test. Okay, this gives you a bunch of scales to choose from that you can assess your patients on. All right, here's an example of a patient showing that unilateral deficit in their face with that facial paralysis, the drooping, facial drooping. Secondary assessment, OPQRST, okay, vital signs, and performing that physical exam. That physical exam is going to be part of your assessment. That's going to be the arm droopage. All right, sir, ma'am, can you close your eyes for me? Can you lift up your arms to about shoulder height? Okay, or you may have to lift it up for them. Okay, and then you're going to take your arms away. They're going to keep their eyes closed, and one arm may drift down on the affected side. All right, here's another example of someone having that non. Oh, the this. Well, wait. This is normal symmetry. Oh, I don't know about that. Face of a non-stroke patient has normal symmetry. Okay. All right. So that is a significant difference. Her, I'd be pretty curious if she was exhibiting that. But I guess when she smiles, she has no problem, and she's able to wrinkle her forehead as well. But this patient, we see some droopage going on. So when they smile, their whole mouth doesn't smile at the same time. And again, we have the patient close their eyes. We have them extend their arms to about shoulder level. And then if it droops, that's called a positive arm drift. All right, so facial droop, arm drift, or abnormal speech or slurred speech. That's that FAS and the FAST acronym. And this is part of the Cincinnati Pre-Hospital Stroke Scale, the FAS. It's probably the most common one that you're going to use. But there are others, the LAPS, the Los Angeles scale, which I think is in that app as well. Here's a drawing of someone that's having a signs of a stroke. All right, maintain their airway. Suction is needed. Because they have that facial paralysis, they may have excessive drooling as well, so we may have to suction the airway. Assess ventilation as needed and position the patient. Okay, we may be positioning them on their left side if there's no spinal compromise. Sometimes you have hospitals that have specialized stroke units that are that have a lot more than we have in the typical ambulance, because they are specifically going out to stroke calls. All right, so real quick, what's the two different types of strokes? Ischemic and hemorrhagic. Okay, ischemic is caused by what? Clots and stuff. Okay, and hemorrhagic are bleeds. Okay, brain bleeds. Assessment every 5 minutes because they are unstable patients. They need an MRI. Okay, they need an MRI to figure out what's going on with that brain. All right, headaches. This is going to be real quick. So headaches, sign or symptom? Symptom. Because we can't see a headache, our patient has to tell us, my head hurts, I'm having a headache. All right, so there's different types of headaches. And has anybody ever experienced a migraine before? Pretty bad. Hope you don't have to go through it. I get them all the time. Okay, because of my TBIs doing the military. So patients that are having migraines, these can be debilitating. So you might get a call across the net that says, patient complains of headache. But you get there and they're having one of the worst migraines of their life. Okay, obviously it's whatever the patient reports to us, but just take that at face value. If you've ever had a migraine before, they can be utterly debilitating where you can't do anything. The pain is so severe. They can cause a lot of vomiting, and which can lead to dehydration, which can affect other problems in the body. So headaches. These could be possible signs that it may be a more significant issue, because what did we say was a sign of someone having a brain bleed? A thunderclap headache. That I'm having the worst headache I've ever had in my entire life. It just came on out of nowhere. Okay, that might be a brain bleed that they're having. So that could be a possible sign that they're leading on to a stroke. All right, so you're just going to constantly reassess these patients at OPQRST, asking for any conditions that they've had, worsening of pain, coughing, sneezing, bending of the neck, or bending over. Okay, that might be. So if someone complains of head pain in their head when they bend over, what might that be? Anybody ever had sinus pain? Okay, you have your sinuses are inflamed, and you bend over and you just have a severe immediate headache, and then once you stand up, it immediately goes away. Fever or stiff neck. Stiff neck, what might that be? Meningitis, okay? Meningitis. How communicable is that? How easy it is to transfer meningitis? Pretty darn easy. So if someone's complaining of stiff neck, one of the first things you need to do is mask up and wash your hands. Okay? Change in the quality of a chronic headache. Okay, so someone that has headaches very often, they can say, look, man, I have headaches all the time. I'm used to it. I take medication for it. But this is bad. This is the worst I've ever felt in my life. Take them seriously because it could be signed as something much, much worse. All right, if you have to, maintain and establish an airway. O2, check their circulation, and then transport. All right, that's all I got for AMS, strokes, and was seizures in this one? I can't even remember. No, that was the previous one. All right, AMS, strokes, and headaches. Any questions, guys?